for this interesting meeting. Thanks, Dr. Yogesh, for the invitation. You have the magic touch always to arrange very successful meetings and very well attended. So my talk is about the basics of successful CBD cannulation. I can see lots of colleagues here that they perform ERCP, and in fact, they may be performing even much more advanced techniques. And whenever we're speaking about a technical issue, we're trying to simplify it, and so it with slides can be challenging. These are my disclosures. Essentially, this is the outline of the talk. We're going to speak about the ductal anatomy within the ampulla, opacification and deeper cannulation of the desired duct, anatomical variations, opacification, guide wire, or both, and other tricks. So, selective common bile duct cannulation is essentially the first and the most important part of the sequential moves that consist the ERCP. It is essentially the key that needs to be put in the keyhole in order to reveal all the pathology and subsequently the therapeutic work that needs to be done in order to help the patient. Without putting the key inside the keyhole and opening the door, it's impossible to do anything. So this is the most important part of the ERCP. So we've seen the papilla many times, and we need to remember the basic anatomy, that the papilla orifice is covered by this fold, and this is the intraduodenal part of the papilla, and it has a lower fold which is projecting. It is important to remember this anatomy because we're going to see later on in the presentation that it's not always like that. And of course, we should remember that for complex ERCPs, that of course is not going to be part of the talk. For example, in patients with Bill's 2, that this anatomy can be upside down. And it is important to remember what is what in order not to cause a perforation. So in a lateral view, we can see that the papilla of Vater is a complex structure that consists of the bile duct and the pancreatic duct that they join together, and they are surrounded by the sphincters, which is circular muscles, individually for each duct and together. And this anatomical configuration makes the selective CBD or even the pancreatic duct cannulation challenging. We should not forget the duodenoscope anatomy. The duodenoscope has two major differences in comparison to the classic scopes, that it is side viewing. So whenever we're pushing the scope, we see from the side. What I used to say to the trainees in the past when I was working in a public hospital and I was trained in ERCP is like walking in this room and looking down. So you don't look straight away, but we are looking down on the floor, and we are trying to move on by looking down on the floor. So this is the same analogy. And the second is this magic instrument, which is said the elevator, that has the ability to elevate up the various instruments that we are using. So these are the two major differences. So we start with the position of the doctor and the duodenoscope. This is an important thing. Personally, it took me many months in order to be able to get inside the papilla in the right position, because it is challenging to learn how to push the duodenoscope into the right position. So, first of all, whenever you introduce the endoscope inside the throat, you're going to have a tactile feeling. You're not going to see, like in the normal endoscopy, the larynx. So you need not to push too hard, but gently in order to feel the give effect, the slide effect, in order to get into the esophagus. Later on, when you're going to get inside the stomach, you're going to be seeing the posterior wall of the stomach. And you, at the beginning, we can see that the doctor is facing the patient. Okay, the patient, in fact, most likely is going to be in a prone position, not in the lateral position. But as soon as we are going to get in the stomach and further beyond, the doctor needs to rotate by 90 degrees facing in the front. And with this way, when we're going to reach in this area, we will not be able to see the pylorus like in a normal position. So we're going to see the pylorus like the rising sun. And then that's the time that we need to push in. If we're going to try to push when we see the pylorus in the middle, it will be impossible to cannulate the duodenum. And eventually, when we're going to get inside the first part of the duodenum, with a gentle move, it's going to get into the second, and we're aiming to get this position. To get this position is challenging, as I said, and it takes a lot of time. Unfortunately, you cannot always get this position, but ideally, the papilla should be in the upper half of the endoscopic picture, not in the lower, ideally in the upper half, so you can be a little bit from below. So we should not forget that whenever we do an endoscopy, we are not working on a 3D mode. We are working on two-dimensional mode. And the 3D mode, the 3D impression is going to come over time with the experience. Only after doing lots of endoscopies and colonoscopies and ERCP, you're going to have the 3D vision inside of your eyes, although you are working with the two dimensions. So whenever we are in front of the papilla, the aim is to be able to align the instrument that we are using with the CBD. But it's not always straightforward, because when we see, you should remember that when you see the papilla in front, we should remember that the common bile duct is in the direction of 11 towards 12 o'clock, when on the contrary, the pancreatic duct is facing this direction. And unfortunately, this is something that we cannot see from the outside, but we can move the tip of the endoscope in this direction, right-hand side, in order to align the tip of the endoscope and the instruments with the 11, 12 o'clock position, or from the other side in the direction of a 3 o'clock position, which is the pancreatic. So these are something that you're going to get by time. Now, how do we cannulate? What is the instruments that we are using? We've gone in various phases. At the beginning, we had the single channel simple catheters that they do not have the ability to bend. But nowadays, the standard trend for many, many years, in fact, is to use these instruments that we call them sphincterotomes, that they have the ability with an external handle to bend and give us a direction up and down, but not also up and down. There are certain brands that they can give the direction right, left, if necessary. And we're using also the guide wires. So nowadays, the guide wired sphincterotome is the standard of care in order to achieve the cannulation. You can have straight guide wires, you can have angle tip guide wires, it depends on the preference. And of course, we should not forget that the help of the nurse usually is of paramount importance, because in most of the departments, essentially, it's a combination between the nurse and the doctor. And of course, there are guide wires of various length, shorter or longer, depending on the preference and depending on whether the doctor himself wants to cannulate or with the help of the nurse. Now, this is something that takes time, the simultaneous coordination by pushing the cannula, the sphincterotome, and at the same time, coordinator with the elevator, which is here, and the big wheel. So this kind of maneuver takes some time to learn. Now, let's try to simplify it, to break down as much as possible. So, important, the position. Position yourself in front of the papilla and a bit lower of it, as I explained before. Now, at the beginning, it takes some time. You need to spend a few seconds, minutes to observe, just to observe the papilla. This may be helpful, and sometimes you need to stop doing anything because there are intense contractions. Of course, you can give an antispasmodic medicine to help it, but sometimes you will be able to identify the orifice of the papilla. You can see some bile coming out, and this may help you to understand which direction you have to go to. we should not over-insufflate the duodenum. When we over-insufflate the duodenum, then the papilla structure is getting compressed. And then we start engaging the guide wire sphincterotomy gently without compressing the papilla, asking your assistant to void gently towards 11 o'clock position, when at the same time we do torque and push with the elevator while withdrawing the scope slightly. Essentially, this is a move that requires a very good coordination between the nurse and the doctor. Alternatively, that's another technique sometimes, is that you can leave a few millimeters the guide wire outside to protrude, and you can do the same maneuver more or less. Now, if you cannulate successfully, then push the sphincterotomy deep, opacify, maybe not fully, and secure the position of the tip of the scope. And you do that by doing right in the big wheel in order to come closer to the papilla. Exhale. This is the difficult part. And all the doctors, no matter how experienced they are, this is some kind of tension. So exhale, you're ready for the sphincterotomy. Now, there is some kind of controversy whether you cannulate with the short route or the long route. There are advantages and disadvantages. With the short route, we have higher stability in the duodenum because you are very close to the papilla, and you have better maneuverability because obviously the maneuverability that you have with the scope is more or less one-to-one. That means you can move the scope with the position of your body, right and left, and this is transmitted at the tip of the scope. But sometimes this is not easy. It's not easy to get the right position in front of the papilla that I showed at the beginning. And this may require to push the scope to make a big loop inside the stomach, and you have the long route. So anatomical conditions may require that, or gastric decompression, if the papilla is a bit lower in the third part of the duodenum, if there is extrinsic compression, or hepatectomy, left hepatic mass, or there is a pancreatic pseudocyst. So this maneuver with the long route should be done in a gentle way because there is always the possibility that you can do a perforation of the first part of the duodenum with the angle of the duodenoscope. Now, when we are trying to cannulate, what we are using? Are we trying to inject some dye or to do wire cannulation? Again, there are advantages and disadvantages. If you inject, you can have a direct anatomical roadmap, so you can see if it is the pancreatic, if it is the biliary duct that you are viewing. You can do it for teaching demonstration. It does not have risks of dissection the tissues in the papilla, perforation, it is less traumatic. But with the wire, you eliminate the risk of repeated pancreatic duct injection that increase the risk of pancreatitis and may improve cannulation success and maybe could be less traumatic. The tendency nowadays, I would say, almost exclusively, is to go with a wire much more than with the injection. Can a guide wire cannulation increase the success rate and reduce pancreatitis? So it seems that there are studies about it, and I'm presenting here a meta-analysis of 5 randomized studies with primary cannulation rate higher in the guide wire group, 85 versus 75%, and the final cannulation rate was 93% in both groups, and use of pre-cut higher in the contrast group. That was more difficult. And the post-ERCP risk of pancreatitis was 0.23 in the guide wire group. Now, we can see different appearances, and this is just very, very few. I would say there is a big, big variation of papilla appearance, and we can see this is a small papilla. We can see a protruded one, a papilla which is compressed by a diverticulum. So the technique is different depending on what we see. So we can see one papilla here, which is at the edge of the diverticulum, an inflamed papilla you will be very, very lucky if you see this papilla. Very rarely, almost never, you see CBD and pancreatic duct separate. So does the appearance of the papilla matter? It seems that it matters, and there are studies that have shown that out of these 4 major types of papilla appearance, you can have different cannulation success. And it seems that the most difficult were these 2 papillas, type 2 and type 3. It was much more difficult to cannulate, requiring alternative techniques. So you need to be prepared for that. Now, there are alternative techniques to succeed the important step of the CBD cannulation. So you can have single guide wire with or without dye, as we said. This is sometimes a combination, or a double guide wire of pancreatic assisted guide wire. You can put a pancreatic stent placement. So sometimes you cannot cannulate straight away. You cannulate the pancreatic duct, you put a pancreatic stent or a guide wire in order to facilitate. You can do a needle knife fistulotomy or a rendezvous technique. We're going to speak about it a little bit. So this is the double guide wire technique. Essentially, we're going to see later on a flow chart. What happens is that it is introduced in patients that the cannulation, the selective cannulation of the CBD is not that easy, and the wire goes more easily into the pancreatic duct, and we keep the pancreatic duct in the guide wire in the pancreatic duct in place, and we're trying to cannulate selectively. Here there is a small video. I don't know if it's gonna play. It doesn't play. Yeah, that was a study that we presented in the UGW in 2013 from my previous experience in the previous hostel that I was working. And in summary, out of around 600 naive papilla ERCPs, the classic cannulation success was around 80%, and in 20% were to do alternative technique. Out of the 20%, 60% was with a double guide wire technique of 86%. The rest required needle life or rendezvous. So this is a very useful technique, the double guide wire, and the doctors that they perform ERCP should be familiar with. Now, after double guide wire failed, what is next? Now, it seems that there are 3 scenarios with a double guide wire technique unsuccessfully. Successful pancreatic duct cannulation, but unsuccessful selective bile duct. Failure to achieve deep PD cannulation and creating a fall passage with repeated guide wire manipulations. So in the first scenario, a short pancreatic stent can be placed, following by reattempt of CBD. So this will help the post-ERCP pancreatitis, but will reorientate the papilla in a more neutral position in order to achieve the cannulation. And alternatively, after securing the guide wire, because this is the other technique, either the guide wire on the pancreatic stent, transpapillary sphincterotomy can be performed, although we don't recommend this technique on a routine basis. In the second scenario, pancreatic duct cannulation is not successful, maybe because of the anatomy. So you cannot get into the CBD, you cannot get into the pancreatic duct. So option to cannulate with a smaller wire, 0.018, or proceed with the alternative techniques like needle knife sphincterotomy. Most of the operators are going to prefer the needle knife sphincterotomy. And in the third scenario, repeated attempts have failed, and you have done intramural passage. So essentially, instead of cannulating selectively the ducts, you have gone through the tissue in between the mucosa or in between the muscles. So this is the most difficult scenario. And essentially, you need to refer the patient to an expert center or wait. So needle knife technique, as I mentioned before, is essentially one technique that you need to be familiar with. and you are trying essentially to open selectively the CBD from the outside. One important thing is to have the landmarks of the intra-duodenal part of the papilla in order not to start dissecting from the side and going into the posterior part of the duodenum, causing perforation. One important thing that you should remember is that you should follow the same plane. This is something that we know from the surgeons. That means that you cannot dissect in one plane and then go in a lateral plane. You should dissect in the same plane. There are variations. There are the operators that they prefer to dissect from up down, or the others that they prefer to dissect from down up. And then, after doing repeated dissections in the same plane, the target is to open the CBD to see a drop of bile and then be able to cannulate from there and extend the sphincterotomy. So this is an alternative technique that whoever needs to do ERCP should be familiar with. Now, if the papilla is going to be inside the duodenum, this could be a little bit challenging. Potentially, this can be reversed with a clip. So you can drag the side of the diverticulum and you can revert the papilla from the outside. So this is, again, something that you should be familiar with. We should not forget the try another day technique, as Dr. Reddy has mentioned 5 years ago in a publication. Sometimes it's not the good day for the doctor, or it's not the good day for the patient. Repeated attempts may increase the risk of the complications, especially post-ERCP pancreatitis. Whoever is doing this technique should have a very strong stomach to go out into the family and say, sorry, we failed today. It's not easy to say that, but you need to be prepared for that because it's going to happen. So try another day technique is a reasonable approach. You leave the patient for about 48 hours or 72 hours, and you go another day, maybe better prepared for alternative techniques, ask the help of a colleague. Nowadays, this can be done with rendezvous technique with endoscopic ultrasound. If you are an operator that performs both techniques, and then this is something that can be done. Now, competency requirements. How many RCPs do you have to do in order to start working on your own? Now, the American Society mentioned about 200 ERCPs that you have to do independently with a success rate of more than 80%. 80 to 90% is accepted as a good number in order to start working on your own. So this needs to be documented. Is this enough to feel confident when you do ERCPs? I believe this is not enough. And I believe that this may be good enough for the learning curve, the basic learning curve, but in my opinion, maybe more than 600 ERCPs would be a reasonable number to start feeling a little bit confident about yourself. Of course, it depends on how many do you do. In Europe, where I was trained to learn ERCPs, we do not have the work volume that my Indian colleagues have. So it takes longer in Europe to be trained in comparison to other areas where the ERCPs are much more. Now, does it make a difference regarding how frequently do you do ERCPs? Now, there are some studies. This is a very old one in 1996 that has measured difficult cannulation, how many times you inject the main pancreatic duct, failures of drainage, hemorrhage, severe complications. You can see the difference in operators that they do less than one per week or more than one per week. Is this applicable to everybody? This is an old study in 1996. I believe this may be applicable in the early phase of the training of the ERCP performance. I believe that after a certain number of ERCP, maybe more than 1,000, 1,500, or even more, these numbers may not be applicable. We should not forget that if these numbers were applicable, the majority of the doctors in the private sector, at least in Dubai, should not perform ERCP. And we should have left them only for the public hospital. Now, in the same publication of Dr. Reddy, 2017, he proposed this roadmap. So you have a selective biliary cannulation, fair enough. If not, after 5 attempts or more than 10 minutes, if you have cannulated the pancreatic duct, you put a stent or you put the double guide wire. It's better to put the stent to prevent post-ERCP pancreatitis. And then you have success of the biliary cannulation, okay? If not, so you go for needle-eye sphincterotomy. If you fail, leave it for another day or do EUS guided biliary access. Now, if you are not able to succeed with the pancreatic duct at all, so you cannot cannulate any of the two, then needle knife. If you fail with the needle knife and it is an urgent case, the patient is septic, you can go for EUS. If not, try it another day. And that was my last slide. Thank you very much for your attention.
Thank you, Dr. Filippos, for this lovely and elegant presentation of the cannulation of common bile duct. I think we have a couple of minutes for 2 questions, 3 questions. Yes, Dr. Nigel.
Thank you, Dr. Filippos. That was a fantastic lecture. I know this was just the introductory things, but can you comment on whether on where people should be sending patients post-bariatric surgery and, for example, bypass surgery, because that is much, obviously, cannulation in those kinds of cases is much more complex. Do you recommend, where should therapeutic endoscopists send those patients? Should they be done by any general therapeutic endoscopist, or should there be more specialized centers for those?
Very good question. Thank you very much. These are the most difficult patients. For patients that have a simple sleeve gastrectomy, it's not necessary to go anywhere. An average doctor who feels confident about himself, he can do it. But the patients that they have completely distorted anatomy, like bypass, mini bypass, then should be going only to specialized centers. I would say you should refer the patients to the best place that you believe that they can offer advanced ERCP therapeutic work. This is not a case for an average doctor who performs ERCP. And in fact, in the American society, as well as in the European society, we know that there are different stages of ERCP. Okay, so this is in the 3rd stage, 4th stage, that there are much more complicated cases, like patients that they do Billroth 2 as well. So, no, this is not a case for an average doctor.
Right.
Yes, please.
When you leave a pancreatic stent following failed selective cannulation of CBD, how long would you leave the pancreatic stent for? Would you remove it immediately after the procedure, or would you leave it for a few days?
In general, obviously, you're going to be tempted to remove it immediately because you don't want to have the patient another procedure. But as long as you put the pancreatic stent, you better leave it there for a couple of weeks. Now, if you put a pancreatic stent that is going to be a single single pigtail, that means the pigtail is from the outside and the stent is straight, and especially if you cut the flange from the pancreatic stent, it's very likely that it's going to fall off on its own. So ideally, after 2 weeks, the stent needs to be removed if it's still there. But before attempting to remove it, always make an X-ray to make sure that the stent is there, because it's going to be very frustrating to put the patient asleep Do an endoscopy, don't see the stent. I say Dr. Khalid is agreeing. So do an X-ray. I would say the X-ray, do the X-ray before the RCP, not the previous day when you saw the patient in the consultation. 5 minutes before, do the X-ray to make sure that the stent is there. But most of the stents are going to fall off. If you're going to put a single pigtail stent in the pancreatic duct and you cut the flange, it's going to fall off on its own. They will not be necessary. So no, leave it for 10 days.
Do you recommend supine or prone position?
Very good question. Traditionally, I prefer the patient to be in a prone position. It creates a little bit of a tension just before, because the patients are going to be intubated, at least in our hospital, and I believe in most of the hospitals of the private sector, patients are intubated by the anesthetist. So then it requires a kind of a teamwork in order to move the patient into the prone position from the supine position, which is the intubation. And if the patient weighs 150 kilos, it is a challenging job. The reason for that is that I believe that we have a more stable position of the scope in the prone, so the scope does not have a tendency to slide back into the stomach, and you don't have the over-insufflation of the duodenum because it is compressed by the table.
Thank you.